Good evening, everyone. I am Arpita, your host for today's session, and you are watching the Obesity Talks HCP webinar series, an educational initiative supported by Eli Lilly. Today's episode is a special edition of our Obesity Awareness series, where we shine a spotlight on an important and fascinating topic: fat is not passive, the endocrine role of adipose tissue. Adipose tissue is not merely a reservoir for excess calories, it's a highly active endocrine organ that profoundly influences metabolism, inflammation, and the development of chronic disease. In this insightful session, leading experts unravel the intricate biology of fat and discuss its far reaching impact on overall health. We will be having two of our experts where Dr. Julka sir will shed light on the pathophysiology and medical aspects of obesity, while Dr. Soni will provide insights into the surgical perspective, including bariatric surgery. Now, I would like to invite our experts for today. First, I would like to start with Dr. Julka sir.
Namaste.
So he's a senior consultant, Department of Endocrinology in Care Hospital, Indore. He runs the healthiest endocrine center in town, Radiance, the Hormone Health Clinic. He is involved in various phase 3 clinical trials since 2008. The cardiovascular outcome clinical trials with obesity and diabetes Sir has performed. The publications that Sir has are 25 publications in national and international journals and contributed a chapter in book Progress in Neuroscience, Medical Management of Pituitary Masses. He has made movies the support for diabetes awareness and exercise, and his movie Shapat was voted for the best patriotic movie in India. He does a lot of work for public awareness and preventive health strategy for non-communicable disorders. Welcome to the session, sir.
Namaste and Jai Hind. Thank you very much, Arpita ji.
Thank you, sir. Next, I would like to welcome Dr. Vishal Soni, sir.
नमस्कार अर्पिता जी.
Namaskar, sir. Sir is a surgeon, educator, innovator in gastrointestinal and hernia AWR surgery with expertise in robot assisted obesity and acute care surgery. He is a senior consultant at the Department of Minimal Access and Robotic Surgery, director of Institute of Advanced Hernia, AWR, and Bariatric Surgery, Apollo Hospital from 2025 to present. He is a recipient of 40 Under 40 Award 2023 by BW Healthcare World for contribution in robotic surgery. He is a recipient of Emerging Icons of Gujarat for surgical services during COVID-19 pandemic award conferred by the Times Group. He has several publications in international and national level. He has been invited in national and international conferences as a guest lecturer or speaker. And the academic events of Sir, he has been organizer are FALS Robotic Surgery 2024 Ahmedabad, HSI Con 2024 Indore, and FALS Upper GI Surgery 2024 Ahmedabad, and so on. So with this introduction, I would first invite Dr. Sandeep Julka sir to present his presentation, sir. Over to you.
Thank you very much, Arpita ji. You will share the slides.
Yes, I'm sharing it.
Will you be sharing the slides, Arpita ji?
Yes, I'm sharing it. Just a minute, sir. I'm sharing.
So, as the slides come on, it is a pleasure to be talking to you all and pleasure to be talking to Dr. Soni. And before the advent of GLP-1 agonists, in 2009, I remember we started bariatric surgery in Indore, and in 2009 we presented our first case series in Vellore, Econ. And one of my close friends, Dr. Rakesh Shivre, we used to do a lot of bariatric surgeries in Indore. And now you know that there is Dr. Mohit Bandari and several other doctors, Achal, and they are doing bariatric surgeries in Indore. Uh, I have had the good fortune of doing clinical trials with practically all GLP-1 agonists, and especially with tirzepatide. I just completed the cardiovascular outcome trials for 4 years with tirzepatide, and I have extensive experience with using GLP-1 agonists, especially tirzepatide, and also the triagonist, which is going to be launched few years from now. So basically, my role today would be to just let everybody know that when you talk about fat, it is just not an innate organ. It is something which is very, very metabolically active. And even if you forget everything what I talk about, the various hormones which is released, just remember that you have to tell your patients and you yourself have to do everything to reduce your intra-abdominal fat, and also do everything possible to make sure that you have a good lifestyle. Now, can I have the next slide, please? As you know, our next speaker is Dr. Soni, who is a bariatric surgeon. In 2025, this June 2025, we were invited as a group to participate in a obesity task force, which was a joint meeting between Endocrine Society of India and the Obesity Surgeons Society of India to develop a country specific guidelines. And 50 of us were brainstorming in one place, and hopefully very good things will come out. So I was part of the advocacy and government policy group. So in advocacy, in the past, say 4 months or so, I have visited practically all schools, because you know that CBSE has also mandated sugar boards in all schools. So idea is to bring about awareness about obesity. Next, please. Before we go on to how obesity and adipocytes cause diabetes and hypertension and dyslipidemia, I will like all the viewers to know that obesity is responsible for 20% of cancers in the world. Can you imagine? And why does this happen? Because there are hormones in the adipocytes. One is aromatase, which converts testosterone to estrogen. When there is high estrogen, that can be cancerous. When there is insulin resistance, there is rise in insulin and IGF-1 levels. When IGF level is high, it can lead to cancers. And adipocytes, which are intra-abdominal, is known as the angry fat, and they cause inflammation. This inflammation is really bad, which can lead again to cancers. Next, please. So these slides I've taken for the CDC, Center for Disease Control, US. Fat cells also produce adipokines, especially leptin, tumor necrosis factor alpha, from adipocytes as well as from macrophages. They all can promote cancers. Adiponectin, on the other side, prevents insulin resistance, increases insulin sensitivity, which actually is safeguards the cells. And then fat cells may also cause up titration of metabolic regulators, leading to mTOR pathway and AMP activated protein kinase, leading to malignancies. So you all have to keep in mind that fat cells are not innate. Next, please. So the traditional view was fat is just for storing energy and for thermal insulation, but now we know they are actually hormone factories. Next, please. There are three types of fats. There is white adipose tissue, which is there in the adults. It is intra-abdominal and in subcutaneous. Then there is brown adipose tissue. Brown adipose tissue more in the childhood. Now this is very metabolically active. It has high mitochondria, and uncoupling protein is upregulated, leading to increased ATP synthesis. So non-shivering thermogenesis is due to brown adipose tissue. And then nowadays it is found that some amount of brownish white adipose tissue known as the beige adipose tissue is also found. Now in future there will be drugs which will target to up titrate or increase the level of brown adipose tissue in the body of adults, leading to improved insulin sensitivity. Next please. Adipokine, there are 2-3 we'll talk about: leptin, adiponectin, resistant, and TNF alpha. Next please. Leptin was discovered in 1994. Its physiological actions are in the hypothalamus, in energy metabolism, in immune regulation, in reproductive function, and bone metabolism. So you can imagine a hormone from the adipocyte leading to so many actions. Next please. Leptin resistance leads to obesity. So if there's a specific leptin deficiency leading to obesity, recombinant leptin was given to treat it, but in other states it doesn't really work. Next please. Then there is this pathway where leptin acts, and then there is this gene MCR4. Next please. Recently we diagnosed a child with monogenic obesity. She had a mutation of this MCR4 receptor. She was massively obese at the age of I think 4 years. And the only treatment will be setmelanotide in this patient. So those monogenic obesity, majority of obesity which we see is exogenous obesity, partly genetic, partly environmental. But there are specific syndromic obesities. Some are like the Beadle-Bardet syndrome, Lawrence-Boone-Beadle syndrome. Some can be gene mutation, single gene mutation like the MCR4. Next please. Adiponectin is the protective adipokine. It improves insulin sensitivity, cardiovascular protection, anti-inflammatory. So we would want adiponectin to increase. Next please. So any fat which is intra-abdominal, which is visceral, so fat in the muscles, intramyocellular fat is bad, fat around the liver is bad. NASH is now the commonest cause of hepatic liver transplantation in the US. NASH leading to cirrhosis. So adipose tissue is pro-inflammatory. Next please. What happens in obesity? Primarily there is adipocyte hypertrophy, and there is dysregulated growth leading to metabolic dysfunction and inflammation. Next please. Our endeavor would be to lose weight and reduce the size. And then this chemokine release leads to all those non-communicable disorders. Next please. There are some other adipokines. I will not go into the detail. Omentin, visfatin, FGF21, epiletin. So all these all hormones are also there, but then let's not go into the detail. But the major ones I've already spoken to. Next, please. What happens? Again, dyslipidemia. We know in Indian phenotype is small dense LDL, slightly raised triglyceride, and low HDL. This again is due to these adipocytes. We have what is known as the thrifty phenotype. Next, please. How does it affect? We know that after a certain weight, girls go into puberty. There is aromatase enzyme which converts testo to estradiol. That is why you get pubertal gynecomastia in boys. So leptin also affects the hypothalamus and the reproductive function. And obesity leads to poor ovulation in women. Obesity leads to decrease in testosterone levels. So all this has to be kept in mind. Next, please. Brown adipose tissue, if we can do something to increase it in adults, that will be favorable. And there are research going on where we would probably someday be able to increase the brown adipose tissue in the body and reduce the white adipose tissue. Next, please. So weight loss strategies could be caloric restriction, exercise, somehow increasing adiponectin, pharmacological approaches, and emerging therapies we'll be talking about. Next, please. Next, please. So what happens in chronic overnutrition? There is adipocyte hypertrophy and increased amount of resistant tumor necrosis alpha and adipokines. Next, please. Again, next, please. This we've spoken about insulin resistance. Now, very importantly, the world got up and took notice of these drugs, which was oral semaglutide, injectable semaglutide, and more recently tirzepatide, which is a dual agonist. Very, very fast tirzepatide was launched in India and it became a 500 crore brand. Why? Because it really targeted obesity, and the adipose cells express GLP-1 receptors, and somehow these incretin axis. What is this incretin axis? This is GLP-1, GIP, and glucagon. This axis affects the adipocytes. Next, please. It is a novel target for incretin axis. So that is why our GLP-1 agonists actually, and GLP-1, GIP, and triagonists have such far-reaching benefits. Not only do they control blood sugars, they control blood pressures, they are renoprotective, they are cardioprotective. And not just this, some of the GLP-1 agonists have shown to be beneficial in Alzheimer's as well. So these are drugs which have far-reaching consequences, and they are very, very beneficial. Next, please. So this is again how does the GLP-1 affects the adipocyte differentiation. Next, please. So when we are fighting the obesity epidemic, diabetic epidemic, it is like pushing this rock. If you've been to Mahabalipuram, this is the butter bowl of Krishna there. This is how we have to fight against obesity. Next, please. Can I have the next slide? And not just that, we have to fight the lay press as well. Every day in WhatsApp University, in so many people talk about getting your weight loss done, fat diets and everything. So you have to go to the right person to take the advice. Next, please. Yes, whenever I prescribe GLP-1, because the cost at times can be prohibitive for people, they always ask, kitna weight kam hoga, kitni jaldi kam hoga. So I tell them, dhire dhire re mana, dhire sab kuch hoye, mali siche sogada, ritu aaye pal hoye. Idea is that everything happens in its time, but these drugs really help you to overcome that barrier of weight loss. Next, please. So various experts in the field of obesity management will tell you separate things. So that is why this Sanskrit shlok, ekam sat vipraha bauddha badanti. That is, various experts will tell you the same thing in different ways. Next, please. So whenever you try weight loss, there is a reset in metabolism, and the metabolism goes down and body tries to regain weight. So even if you plan to lose weight with these drugs, you have to maintain it by diet and exercise. Next, please. So one of my friends has made this mnemonic acronym: diabetes, hypertension, obesity, lipids. So these are the four big problems: diabetes, hypertension, obesity, lipids. And how do you address it? By Bhangra. Bhangra means behavioral change, happiness, active lifestyle, nutrition, glucose control, risk reduction, and abstinence. Next, please. So lifestyle modification, again, all those points are very important. Stress is, to take care of stress is also important. Chronic stress can lead to increase in cortisol, leading to insulin resistance and obesity. Next, please. Which exercise is best? One would ask. So I feel that it is the cardio plus weight training. More emphasis on cardio plus weight training. Weight training gives you the afterburn. Weight training gives you better muscle strength. Muscle strength causes insulin sensitivity to go up. Next, please. Can we have this video? Yeah. It's playing without the. So this is me exercising. So what am I doing there? I am doing cardio. I am doing muscle training. When I do cardio, I burn fat. When I do muscle training, I make sure that my intermyocellular fat goes down. There is increased insulin sensitivity. There are GLUT4 receptors in the muscle which absorb glucose independent of insulin. So all this is taken. Next slide, please. And I hope that everyone who's listening to us exercises. Next, please. Physical activity, everybody's got to do it. Everybody knows. Next, please. Why are drugs underused? Because there is less physician awareness. Hopefully, after this talk, more of you would be start using GLP-1 agonists. Next, please. Next, please. Before we use any drug, sit back and see what could be the contraindications. For GLP-1 agonist, pregnancy, lactation, medullary thyroid carcinoma probably, and pancreatitis could be one of the reasons where we won't want to give GLP-1 agonist. Beyond that, anybody with a BMI of more than 27, 25 can be given GLP-1 agonists. So there are drugs which were initially planned for diabetes, but then they cause significant weight loss. Next, please. Whenever you start, there'll be 10 people telling the patient, don't take the drug. Just as Amitabh Bachchan told this elderly lady about Dharmendra. I hope his soul rests in peace. Dharmendra ji passed away recently. But if you remember that Sholay dialogue, he went and, although he was telling for his friend, but he was telling all the wrong things. So people get to know all the wrong things about these good drugs. Next, please. There are drugs available in India for weight loss. Drugs in the sense oral medications, mainly metformin, SGLT2 inhibitors, and orlistat. Then we have the liraglutide, which is available. We have semaglutide, which is available, injectable oral. And then we have the tirzepatide, the blockbuster drug. Next, please. How does it act? It acts on food intake, insulin secretion, gastric emptying. And since we are talking about dual agonist, the GIP, in fact, what I have noticed is there is less nausea and loose motions and vomiting with tirzepatide, because probably GIP is protective for that. And it works wonderfully well. So what do you expect? Sometimes when the patient is given this, the patient loses weight, he comes off insulin. The OHA, the diabetes may go into remission. That is what we've seen. Next, please. So there are several more drugs on the pipeline, craglentide and everything. So that is going to come. Retatrutide is going to come. Next, please. So what amount of weight do they lose? Tirzepatide, we've seen massive amount of weight losses, around 20%. So a 100 kg person coming to us loses around 20 to 25 kgs in 3 to 6 months. Retatrutide, which we are already doing a clinical trial with, again, massive amount of weight loss. And of course, bariatric surgery, Dr. Soni will be talking about, loses around 30% and more. Next, please, depending on which procedure you do. This is retatrutide, almost 25% weight loss. Not launched, but since we are doing a clinical trial, we know how it works. Next, please. Nowadays, bariatric surgeons and endocrinologists have turned friends. We are not foes. As you saw that we did a combined task force, which we are working together to get the best possible for our patients. Nowadays, after bariatric, tirzepatide has been used. Next, please. So this is a patient. We'll just go quickly. This is a patient who was 95 kgs, BMI 31, diabetic. Next, please. And we started tirzepatide. So what do we expect? Of course, Basic is lifestyle modification, diet and exercise. What sort of exercise? We already spoke. What sort of diet? Caloric restricted diet, less carb diet, complex carbs बढ़ाना है, less fat. Next, please. And then daily activities. You don't really need to go to the gym. Those of you who follow me on Facebook and all, I exercise practically everywhere. So anybody can exercise anywhere. Next, please. Patient was started with tirzepatide. Next, please. You start with 2.5 milligram, then 5, then 7.5, and 10 and 15. Next, please. And when the weight loss was there, the diabetes goes into remission, the insulin goes away, significant improvement in obstructive sleep apnea, dyslipidemia, antihypertensive medications also go down. Next, please. So this is my last slide. I think I took 5 minutes more than what I was advised to take. But then in crux, you should know that the fat at the appropriate rate is okay. Disproportionate fat distribution intra-abdominally is not good. Make sure you remove it. That is by lifestyle changes, diet, exercise, and some drugs. Don't shy away from prescribing these drugs. Thank you and Jai Hind. Yes, Arpita ji.
Thank you so much, sir. That was an excellent presentation. Thank you. Thank you once again. And now I would request Dr. Vishal Soni, sir, to share his view points. Over to you, sir.
Yeah. I was listening to Dr. Julka very patiently and very nicely. And I think so. He made some fantastic points. I would agree with practically everything that he said. And in my talk, what I will be doing is I would throw some light regarding the understanding of how surgeons perceive obesity and the fat metabolism, and how does the bariatric surgery come in picture. When do we do it? How do we do it? What are the options that the patient can seek? And in the end, we'll have some discussion regarding how we also use pharmacotherapy, endoscopy, etc., and where it fits into our treatment plans as well. Okay, so let me share my slide till then. Give me a minute. There we go. Okay, is my slide visible?
Yes, sir. It's visible.
Arpita, is my slide visible now?
Visible, sir. It's visible.
Okay,
And
okay.
go ahead.
So, greetings to all the viewers who have reached till now and who are still inquisitive regarding what a surgeon would want to say. I think so. Dr. Julka did a fantastic job. He gave us deep insights into how do surgeons, how do physicians, they see this complex problem which affects practically every system in the body, and what are the treatment options available, and what he mentioned regarding the physical activity being the cornerstone of managing obesity. I think so. I would reiterate that in my slides to come. I give you greetings from my team at Apollo Hospitals, Ahmedabad. We are a very proud team. We manage one of these complex cases day in, day out, and we are a bariatric and a robotic unit, and we feel very happy when we can help our patients with the best possible technology. Now, again, reinforcing what is coming ahead, just the way we perceive global threats in the form of what recently happened with COVID or global warming. I think so. The world is moving towards a state where our increased screen times, our decreased physical activities, and our eating habits are slowly pushing the entire population towards higher BMI. And obesity is right now can be perceived as a global threat, a global phenomenon, rather than something that is affecting pockets here and there. Some theory regarding it, again, I would repeat it. Adipocyte is not just a storage facility, it is not merely a place where fat would go and get deposited. It is a two-way communicating tissue where body communicates with the tissue, the adipocytes, and in return the adipocyte also communicates with the body by secreting tons of hormones, tons of chemicals. So if you can see my screen clearly, brain, kidney, pancreas, liver, you name a system and it gets affected. Fat has something to do everywhere. If you go down to the microscopic levels and even the cellular levels, you'll see that adipocyte influences metabolic pathway all across the body. So your liver would generate whatever energy it's supposed to, and the consumption is done at the level of the brain, the heart, which is nearly the static one, but the muscle is where the variable portion of consumption of energy happens. And just the way we saw Dr. Julka burning his calories, if and when you utilize your muscles well, you know that the ATPs would go away, your cardiac activity improves, and this is how all the systems remain in check. And this is how you can keep the adipocytes in check as well. Because again, adipocytes secrete a ton of chemicals. Every chemical has some specific roles and they influence every single organ in the body. So this is not a passive organ or a passive mass that is sitting on your belly, but it is actively communicating and playing role in your health and happiness. Think of it as a stock exchange where there is a constant movement of things. You buy, you sell, and in that there's either a profit or there is loss. So your adipocytes virtually behave like these mutual funds, or if so as to say. But you know what, if you do not tackle them well, there is a lot of loss coming up. Going on to some small numbers so that you can take decision if you're a patient, if you're a healthcare provider, if you're a general physician. Using these some numbers, you can identify if your patient falls in a category where there is some action that needs to be taken, or he or she needs to see a physician, Dr. Julka, or he or she needs to see a surgeon for a bariatric surgery. We typically calculate something called as a body mass index. It is kind of a way in which we realize what God has made this body for. This is the amount of weight that the body is made for. So we have a formula where we use the height and the weight and we calculate the BMI, and the ratio denotes where the patient sits or where the person sits. Typically, these values are lowered for Asians, and there is a strong reason why. Because even at lower BMI values, Asians, you and me, majority of us, we would have higher cardiovascular risk all the times. Now, because we are at higher risk, we should start acting even at lower BMIs as opposed to our Western counterparts. Let me tell you how obesity in real life would give you diagnosis which you would read day in and day out. So if you have diabetes type 2, you have cardiovascular disease, you have fatty liver, you have CKD, you have gallstones, you've been diagnosed with asthma, sleep apnea, obesity related hypoventilation, osteoarthritis, chronic back pain, or you suffer from gout. This is a situation where you should get evaluated if obesity is playing an important role and if it can be corrected, and what are the options available for you. So when the obesity is got diagnosed and we know that we need to treat it, so these are again some numbers that we look at. If your obesity, if you're a patient or if you're a doctor and seeing a patient, if you start the treatment, these are some numbers that would remain in back of our minds, where we want the patient to lose at least 50% of their excess body weight. We want them to remain healthy. We want their BMIs to be lower than 30, in an ideal situation less than 27.5. And I would expect resolution of comorbidities, reduction in the fat that is visible and not visible, and growth in lean muscle mass so that there is metabolism and burning of ATPs. And overall, I'm looking at an improvement in quality of life. Now, again, when do these patients need a surgery? Okay, the problem statement, when it increases, when BMI would be higher, we would have to think of something that is more aggressive. So typically, if the BMI is more than 37.5 for an Indian or an Asian patient, if the BMI crosses 32.5 with at least one medical illness, which means that this patient already has started developing issues because of chronic obesity, or even with lower BMIs like 30 but uncontrolled diabetes, these are patients that can benefit with a surgical intervention. Let me say again, can benefit. It doesn't mean they will benefit, because obesity is a multifactorial event. There is no single cause of obesity, therefore, there is no single treatment of obesity, which also means not everything works perfectly fine even when you do it in the perfect way. So you need everyone's help. You need a team approach to make sure that the patient has been seen by, treated by everyone, and that is how you achieve your best results. When I, as a surgeon or as a physician again, when we take on to these tasks of managing obesity, all we desire, all we want, either medically or with support groups or with surgery, is let's make sure that there is decrease intake of food. Even if patients feel that they're not eating much food, let us make sure that that is correct. Let us maintain a food diary maybe, and ensure that the caloric restriction is in place. In surgery, what we typically do is we'll make sure that the fundus of the stomach, which secretes a hormone which gets you hungry, ghrelin, is decreased, and that would drive away the hunger pangs, and that is how there is early satiety. The patients feel happy with lesser amount of food. It can be medical, it can be non-medical, it can be even with meditation, but this is one goal that I want when I'm treating my patient. In some way or other, I would want to bypass the small intestine, and when this comes in picture, essentially I'm talking of surgery. And with all these factors in place, what happens is the milieu of the GI hormones, it changes to a favorable one, and that helps the patient reduce weight and become more healthy. Now, surgical option wise, there are at least a dozen accepted options available, and the surgeries have evolved tremendously over past, say, 5 decades, and they continue to evolve even till date. Broadly speaking, if you are a patient and if you've been advised these kind of surgeries, you'd come across one of these four names. And if you are a general physician, you should know that your patient would need one of these four surgeries. And if you are a bariatric surgeon or if you are an endocrinologist, I'm pretty sure this is going to be a revision for you. So you start with an option called as sleeve gastrectomy, which essentially means reduction of the stomach, making it look something like a sleeve. You do something called as a bypass, where essentially you would want to bypass a portion of the alimentary tract so that the patient gets benefit with weight loss. There are variations in the same with one anastomosis gastric bypass, also popularly called as mini gastric bypass, and some procedures which are called as sleeve plus procedures. Now, because a lot of you would not be surgeons, a lot of you might not be bariatric surgeons, so we will not go in tremendous depth in individual surgeries. But what I'll do is I'll show you a little glimpse into what goes around and what happens when these patients are indeed operated. So, this particular surgery, sleeve gastrectomy, concept is stomach is huge. It's in shape of a matka, a dhol. We just heard Dr. Jolka. We want to decrease the capacity of the stomach and we want to exclude the fundus. So we use something called as a stapler. Stapler is a special device. It can cut and join some tissues. So what you're seeing on the screen is a stapler coming in, and I am stapling off the stomach. Typically, 90% of the stomach would be cut, and this is a permanent procedure, which means there is no coming back from this. The tissue which is cut is permanently removed from the body, and you cannot undo this particular step. What the patient is left with is a small pouch with a capacity of about 100 ml, and the expected weight loss is about 60 to 70% of excess body weight. Now, important part, this weight loss is not going to be overnight. It typically takes anything between 8 months to 18 months, depending on a lot of factors. So please do not expect magic. This is a slow burn. This is like a test match. You need to play it slow to get good results. The other option in sleeve itself, now again, just know the names, that there are more procedures where you feel that only restricting the stomach may not work well. You also want some malabsorption, which means you want to bypass the stomach in some way, in the small intestine in some way or other. So you have duodenal jejunal bypass, or you have a proximal jejunal bypass, etc. These are complex surgical terminologies. You need not understand all of them, but understand that sometimes mere sleeve does not work, and therefore sleeve plus is an emerging concept. There is so what I'll do is I'll skip this one because this is core surgical concept. I would touch base on Roux-en-Y gastric bypass, which by far and large remains the gold standard procedure because it gives one of the most aggressive weight losses. 70 to 80% of excess is a conservative number. Patients have lost up to 90% or even more when they diet well, when they exercise well. They have lost all the excess body weight that was supposed to go away. Now, again, the good part, this is a reversible procedure. You create a small pouch of the stomach, and that small pouch is then directly connected to the small intestine. So think of it that way. There is a 5 bedroom hall kitchen, large uh, home that you stay in. You suddenly create a wall and you make sure that the 4 bedrooms are not reachable anymore. So your home automatically becomes a little small, and then you give it a direct pathway for exit. So that way the entire capacity becomes small, and there is also malabsorption. So that is the crux or the concept of gastric bypass. Okay, there are variations in the same, the way we do it, why we do it. I think so that is a core surgical topic, not something that I would not like to discuss right now. But understand that there are other options in gastric bypass as well. The way we do it, the way the body gets affected is a little different than classic Roux-en-Y gastric bypass. This decision regarding what is best for you is best taken by an endocrinologist and a bariatric surgeon jointly regarding what should be the pathway ahead. Coming to one topic which is very close to my heart, that is robotic bariatric surgery. Laparoscopic surgery, or the keyhole surgery, which is commonly used for bariatric patient, is gold standard. Of course, you would not be able to cut open, and even your hand would not reach in. But understand that as we see more and more obese, extreme obese patients, even those instruments have their own limitation, and that is where a robot comes in place. It's a specialized equipment, it does not work on its own. A surgeon is always there guiding and kind of ordering the robot regarding what needs to be done, and the robot follows the order exactly the way it is given. And that is how, using a robot, the surgeon does excellent precise surgeries. And this entire benefit is now being given even for bariatric patients, and we have excellently good results with robotic bariatric surgery. And what happens when all of it is achieved well? Globally, every single organ has some benefit, right from brain all the way down till your veins. If you're a patient with varicose veins, you've been diagnosed with venous stasis ulcers, even that would go away or heal on their own with reduction in weight itself and with better dynamics. So every organ of your body which is taking the stress gets de-stressed, and that is how they start functioning better. And this is how we kind of help the patient overall, not just by looking good. Are there any non-surgical option? Answer is yes. They have some limitation, they have some strength. Would I use it in all patient? Answer is no. Would I never use it? Answer is no. So some specific situations do warrant usage of endoscopic options as well. Again, something that you should discuss with your treating surgeon. That person is the best guide whether you should go for these options as well. And what Dr. Julka said, pharmacotherapy has absolutely changed the game. You would definitely hear these words known as Ozempic and Monjaro. They're superbly famous. Should you be again using them? What dose is good for you? What to do about complications? It's best done when you see one of endocrinologist or one of surgeons who can initiate these therapies, keep you in close watch. They make sure that you also diet well, you also have change in behavior, you also exercise. You remember the muscle that I showed you? If you use your muscle, the ATPs get burned, and that is how you remain lean and thin, not just by popping a pill or taking an injection. And then these drugs are not completely safe. There are some GI side effects. There can be need of prolonged use. There is some loss of muscle that can happen with these drugs as well, which worries me as a surgeon. Long term safety beyond few months or years is still a question mark. Not that I get scared with it, but I would like more information when we are doing and using these kind of things for broader population, and the cost is still prohibitive. I would always take a judgment regarding prolonged medical cost of drugs versus a surgery which can be a little more aggressive. So, with that, I would end my talk and I would be open for questions. Thank you so much.
Thank you so much, sir, for that lucid presentation. Now, I will like to take the questions from our audience. So, the first question I would like to ask Dr. Julka.
Yeah.
Sir, this question is for you. How do you practically assess adipose dysfunction in routine OPD? Are there any simple clinical markers or pattern you rely on?
How do you monitor adipocyte dysfunction?
Yes, sir,
Is
in
that the
routine
question?
OPD.
No, I don't. I
Yes.
just don't monitor adipocyte dysfunction. Neither do I want anybody to monitor. There is the only thing you need to do is to know whether your patient is obese or not. That you can find out by looking at the patient. अब प्रोज एंड कॉन्स बीएमआई के भी रहेंगे, बॉडी फैट एनालिसिस के भी रहेंगे, इम्पीडेंस मेथड के भी रहेंगे. भाई आप देख के बता सकते हो मोटा कौन है और कौन नहीं है. देयर इज अ कैटेगरी ऑफ पीपल विच आर थिन बट मेटाबॉलिकली ओबीस.
Yeah.
पतले होंगे बट दे विल हैव अ इंट्राब्रोनल फैट विच इज मोर. देयर बी अ सबसेट ऑफ पीपल हु आर ओबीस बट मेटाबॉलिकली थिन. सुमो रेसलर्स कहते हैं कि दे मे बी ओबीस बट दे आर समटाइम्स वेरी फिट. तो the question should be कि how do you decide to treat. तो treatment or management in a patient would be by when you take the history, you take all history regarding OSA, dyslipidemia, NASH, PCOS, diabetes, hypertension, premature CAD, सब लेके और अगर वो obese है तो then you plan your treatments. So there is nothing which will tell us adipocyte dysfunction. Neither would I want anybody to measure those adipokines or tumor necrosis factor. Even C-reactive protein highly sensitive का कोई मतलब नहीं है. आपको मालूम है कोई abnormally obese है तो उसको दवाई देनी है तो देनी है.
Right, sir. Thank you so much, sir. Next question is for Dr. Soni. Sir, can a person with BMI more than 50 lose weight with diet, exercise, and medicine only?
Uh, so this is a very common scenario. I'm pretty sure Dr. Julka will agree with me that we get BMIs in huge numbers, and the patients mentally would always say, "Sir, आप मुझे 4 महीने दो, आप मुझे थोड़ा समय दो, मैं डाइट करूंगा, एक्सरसाइज करूंगा और मैं वेट लॉस कर दूंगा. मुझे मेडिसिन नहीं चाहिए, मुझे सर्जरी नहीं चाहिए." So I often tell my patients that there is a reason why you reach BMI 50. Not everyone reaches BMI 50 or 40, 45. These are huge numbers. Okay, that does not happen overnight. It's a slow grill which happens over many years. There will be some component of behavioral issues, but there will always be some genetic or some factors which are not under their control. That's the reason why they have reached here. So I tell them that with good diet and exercise, you will get fitter, you will get charged up to take care, charge of your health in your hands. I feel very happy. But would you be able to lose, say, 50, 70 kgs of weight just by this? Answer is no. It may happen 1 in 1,000. And what happens is they many times they see these videos on YouTube where someone has lost 60 kgs with exercise and all. Most of the times it is not true. They would have definitely taken some drugs, they would have done some intervention with which they reached that amount of weight loss, and there will be some help that the person needs, there will be some guidance that the person needs. So I think so instead of fighting, you should always involve your physician, you should always involve your surgeon and say, using your help, how can I get more healthier? That's the answer. Okay.
Right, sir. Thank you. Next question is for Dr. Julka. Sir, in patients with obesity and metabolic syndrome, how do you decide when to suspect adipose tissue inflammation as a driver of insulin resistance?
Any patient walking into your OPD who is obese, has acanthosis nigricans, has insulin resistance, and has angry fat. The fat intra-abdominal is causing insulin resistance. Fat in the pancreas is leading to insulin resistance. Intramyocellular fat is leading to diabetes. So उसमें measure करने जैसा कुछ भी नहीं है. Even a clinical marker of acanthosis and necrocodon means insulin resistance है. आपको उसको treat करना है, metformin देना है, SGLT2 देना है, आपको उसको semaglutide देना है, tirzepatide देना है, वो देना ही है. So it is only a question. हमारे पास पहले ज़्यादा we didn't have many weapons in our armamentarium to treat. अब तो हमारे पास embarrassment of riches, हम कितना कुछ दे सकते हैं. So clinical देख लो and then you have to treat. There is nothing that you need to do a molecular study to start any treatment. है ना?
True.
Right, sir. Sir, next question is for Dr. Soni. I have heard that there are medications needed after bariatric surgery. Is it true, sir?
So, commonly, what happens is whenever you're doing bariatric surgery, you are making sure that the patient's stomach capacity is smaller than what should be. You are also probably ensuring that there is some bypass with which there is loss of that causes malabsorption. So, you are yourself causing malabsorption. So, when that happens, patients also lose essential nutrition, okay, in their diet and in their poop. So commonly after any bariatric procedure, it is given that the patient will need lifelong nutritional supplements. So you should not think of it as medications, okay, these are nutritional supplementations. And there are a lot of people who take nutrition supplementations just like that, even without any bariatric surgery. So you should think of it as a supplement to what you are eating, rather than needing a tablet, or it's not a drug. It's most of the times nutrition supplements. Yes.
Right, sir. Right, sir. The next question is for Dr. Julka again. Sir, do you use any specific investigations to identify altered adipokine profiles in clinical practice, or it's mostly research based?
So probably we should not have kept that adipokine wala part of the talk. Adipokines का it is just to tell you कि अपने fat को ध्यान रखना है, and that fat is causing a lot of problem. It is just research based. Do not to be used. Leptin as a drug is used in specific kinds of, say, obesity. Beyond that, no roles at all. But we know what these adipokines do. Beyond that, no role at all. It is just investigate research based tools.
Makes sense.
Right, sir. Another question for you, sir.
Yeah.
How do you manage patients who have normal BMI but clear signs of metabolic risk?
Yeah, so that is what I was saying. Thin but metabolically fat. So Indians have what is known as thrifty genotype, thin fat phenotype. We are thin but still have a lot of intra-abdominal fat. That is why WHO says beyond BMI of 25 we are obese. And there will be several people who are thin but still have an SGOT-PT which is high. For them, you need to give treatment. What treatment will you give? For somebody who has insulin resistance, a drug will be pioglitazone. Pioglitazone is an insulin sensitizer. It is thought to cause some amount of intra-abdominal fat shifting from intra-abdominal lesion to subcutaneous tissue. Another drug will be metformin. Metformin is good for people who are thin. There is no problem. So you have to address the pathophysiology by giving insulin resistance, lifestyle modification, glycemic control, dyslipidemia control, everything together. Yeah.
Thank you so much, sir. Next question is for Dr. Soni. Sir, can at least one try medicines before going for the bariatric surgery?
Yeah, I think so. This me and Dr. Julka should jointly answer. Most of the patients would always say, "Sir, एक काम करते हैं, surgery के पहले हम ये drug try कर लेते हैं, ठीक है?" And we'll see what happens. Now, uh, this is an increasing trend. Is it wrong? I don't have clear answers, because there are just so many surgeons and physicians opting for that. As a starting point, if there is a small weight loss that can help the patient lose some weight, make the patient more active, like if they start exercising, I would get an optimized patient to do a bariatric surgery. In no situation a 150 kg patient would lose that 60 kgs or 70 kgs of excess body weight and come down to 75 kgs. But if the patient ends up losing, say, 20 kgs, in the meantime, if the patient has started walking better, he started breathing better, his liver has got a little better, I would get a better patient to operate. And therefore, these days we do not say no to it. We actively involve an endocrinologist, and we say that, you know what, this is a great idea, let's do this, let's get some benefit out of medication until the time you prepare yourself mentally that a surgery is coming up. And it's more of a holistic approach now, instead of cross that, either medicine or surgery, aisa nahi hai, it can be both. I agree. And what do you think, Dr. Chulka?
So I totally agree. Now, देखो, with with experience, you get to know what patient will do well in a particular therapy modality. So, some even in fact, yesterday I referred a patient directly for bariatric.
Perfect.
Huh? So 153 kgs,
Perfect.
severe OSA, and I know that sometimes I want to get rid of that fat faster. Sometimes affordability is a problem, so
Yes.
I might send the patient directly for bariatric. But nowadays, majority we always ask them to take medications.
Yes.
Medications have not only the weight loss, they have pleiotropic effects as well. Not that bariatric surgery does not have pleiotropic effects. It very well affects the adipokines also.
Yeah.
The remission of diabetes is more with bariatric.
Yes.
So there is no doubt about it. But then nowadays with these GLP-1, GIP and then triogonist which is going to come, they are going to cause weight loss of like 25 to 30%.
Wow.
So then definitely what we are going to tell is we will put everything on the table that this is what you're going to take. And one thing more, when you give these drugs, you have to give them long term. So although I tell my patient, let's fix a weight. If you're 118, let's fix 80 kgs. Let's lose this much and stop. But then maintenance of that weight loss will be diet and exercise. It
Right.
is not that weight will not increase again. Your genes are the same. But since you've lost weight, you'll be able to do that much more exercise. That much more you'll be motivated more. These drugs are like chronic drugs like hypertension and thyroid and everything. So either you take them or you lose weight and then you're so motivated that you can continue losing weight.
True.
So it is a, you can choose the best from both the worlds. You can have best of both the worlds. क्या लेना है? So आपको जैसे एक बड़ी इंटरेस्टिंग चीज बताता हूं. महर्षि अत्रेय थे, who was the guru of Charak. He used to say that four things are, if they are in synchronization, any therapy will be successful. Jankar doctor, doctor who knows his trade. Patient has to be sensible enough to understand what the doctor is saying and follow the instructions. The attendant who is sensible and make sure that the patient also follows instruction, and the drug, a good drug. If you have four of these which are in synchronization, the therapy will be successful. So that is what we have to do. The attendants also have to be very careful because there is a lot of cost both in bariatric, both in medication. So the cost of going into this therapy has to be discussed with the patients. What are the possible side effects? Lot of patients. So 6 out of 10 will have nausea. 2 out of those 10 will have to stop these medications due to loose motions and nausea and everything. So, and some recently we held a seminar and that is available on YouTube by the name of Dil Ziddi Hai. Lots of patients, they lost 38, 40 kgs on these medications. They all came on camera to speak. So, lot of things are there, lot of exciting things are happening, and we can now choose between what is best for a patient.
Perfect.
Yeah.
Right, sir. That was holistic and practical both ways.
Yeah.
Thank
Yes.
you. Thank you so much. Next question is again for Dr. Soni. Sir, if
Okay.
patient have hernia and obesity together, then what should be done?
This is again one group which almost coexists together. So, if I have to give you some number, 60 to 70% of my patients with hernia, they will be obese, and 40% of patients who are obese will have some sort of hernia here and there. Now, what we typically follow is that if and when the patient is not in a critical state, I would always expect, or I would always want the patient to manage the obesity first and then come with the hernia, so that the um, chances of hernia surgery success increases, a lot. Going and directly tackling the hernia with neglecting obesity most of the times is a bad option. We sometimes do that in emergencies if the intestine has got stuck, if there's a complication like perforation, etc. So only in emergencies, answer is yes. In a planned situation, I would always want the patient to first manage obesity, make sure that they are in the healthy bracket, and then we do a concomitant surgery most of the times.
Right, sir. Thank you so much. Dr. Julka, one last query for you. That is, are there emerging therapeutics or that like directly target adipose endocrine pathways, and what does current evidence suggest about their clinical relevance?
So, a very good question. So the first drug was leptin. The second drug which they are trying to find out is the drug which upregulates the brown adipose tissue in the body, which will help non-shivering thermogenesis. The fat will be insulin sensitive. That is there. Then you can have drugs which can alter then you have drugs which are acting on the MC4 receptor, the set melanotide. So there are lots of drugs in the pipeline, but the best we have now is the GLP-1, GIP-1 agonists. How they are going to affect the fat, we may not know. Maybe they are doing it in pathways which we've not found out till now. And it's an exciting field. Lots of new drugs will be brought forth, and let's see what happens in future.
Right, sir. Sir, this one last query to Dr. Soni. Sir, what is the upper limit of age for being eligible for bariatric surgery?
Now there's some evolution in this number. Okay, previously anything above 55, people surgeons would feel skeptical for multiple reason. One, they'll be unfit for anesthesia point of view. The obesity related issues they add on to the risk of anesthesia, and the fact that even if they lose weight, what happens to the longevity, etc. But as we evolved, the longevity of the patients have increased, and now we see more and more elderlies who come to us with some concerns or some medical issues where there is some role of bariatric surgery. So if I have to pick a number, then up to 65 there have been case reports and there have been practices where patients have benefited. What type of surgery, etc., I think so that depends a lot on what patient is sitting in front of me. But say 60-year is something with till that time I would not think twice. I would offer them if it is clearly indicated, but I would stretch till 65 as well. Dr. Julka, what is your view on this?
So nowadays, I don't know, you can equate, but
Oh,
nowadays I've seen pacemakers being put in 80-year-olds, TKR being done in 80 years old, hip
yeah,
replacement.
yeah,
I'm sure with the advancement of what Dr. Vishal and all surgeons are doing with robotics, I'm sure with better anesthesia techniques, they'll be operating, I'm sure, till 70s.
yeah,
Why not? Because life expectancy is there. We have a prime minister who is 77 and see how active he is.
yes,
Ajit Doval Saab is now almost 80, is leading
yes,
the country.
yes,
So I think, as Dr. Vishal said, it is in evolution. It is a
evolution.
state of flux.
Yeah,
Everything will change with time.
yeah,
And that is how it should be because we learn new things.
yeah.
Yeah.
Right, sir. We would like to conclude, but before that, last takeaway point, one from endocrinology perspective and one from a bariatric surgery perspective.
Okay.
Please, first, please.
So basically, you have to remain fit. If you are fit, you will be able to inculcate that in your patients. I can see that Vishal is fit. I am relatively fit. So the doctors have to take care of themselves to motivate others. That is one. Secondly, start with children because childhood obesity is a big problem, and that is why now when they grow into adults there'll be a massive epidemic of obesity, pre-diabetes, diabetes. Start early, inculcate habits of exercise and diet control. That is from me. Thank you.
Great. From a surgeon's perspective, I tell you what, most of the times patients they do not want a surgery. They are very happy with medicines. Their acceptance of medicines is better, but surgery is something that everyone fears for a lot of reasons. Okay, what I would want everyone to know or understand is there is either life with disease or there is life with a solution. या तो हम बीमारी के साथ जी सकते हैं, या तो हम ये रिस्क लेके सर्जरी का, अगर उनके मन में ऐसा है, हम आगे बढ़ सकते हैं. अगर इफ आई एम माई सेल्फ अ पेशेंट, माई थॉट प्रोसेस वुड बी के अगर कोई चीज सॉल्व कर सकते हैं, उसके लिए जो भी करना हो वो कर लेना चाहिए. और स्पेशली अगर आपका सोल्यूशन काम कर रहा है, तो आपको उसमें आगे बढ़ना चाहिए. सो इफ मेडिसिन इज वर्किंग वेल, प्लीज गो अहेड विद दैट. एंड इफ इट इज नॉट वर्किंग वेल, आपको एक एक सिग्नल मिलना चाहिए कि अब हमें कुछ और करना पड़ेगा. मे बी सर्जरी इज बेटर ऑप्शन, एंड मोर अग्रेशन चाहिए हमारे ट्रीटमेंट में, और सर्जरी करवा लेनी चाहिए. अगर आप बुढ़ापे में सर्जरी करवाओगे तो उसके फल आप पा नहीं पाओगे, या फिर उसको एंजॉय नहीं कर पाओगे. सो इफ यू आर in your 40s, if you're in your 50s, and if you are obese, in that bracket, you should get it done early rather than wait till 55, 60, have a ton of complications, and then probably get unfit for surgery. So अगर जरूरत है तो है, और है तो फिर जल्दी करवा लेनी चाहिए. Okay, that will be from me.
Right, sir.
Thank
Thank
you.
you. Thanks to both of you for your insightful and informative presentations and for taking up all the questions. Sir, your expertise has added immense value to our today's session, and we are truly grateful to both of you for your time and for your contribution. Thank you so much. Thanks to all the viewers, and thank you all. With that, we are wrapping up for today. Thank you. Thank you so much.
Namaste, Jai Hind.
Jai
Good
Hind.
night.
Jai Hind, sir. Thank you. Good night.
Bye. Bye.